Welcome to the Deep Dive. We're here to break down complex topics so you can get right to the core knowledge you need.
And today, we're diving into Chapter 18 from Fundamentals of Nursing. It's all about planning and outcomes identification in nursing care. Think of this as your shortcut to mastering these key concepts.
We all plan things every day, right?
Aren't
Like
we?
making a grocery list, planning your weekend. You figure out what needs doing and how you'll do it. Simple enough.
Right.
But what we're talking about today, planning nursing care, that's a whole different level. It's incredibly complex and honestly, way more critical.
Absolutely. It's not just a to-do list, it's the nurse's strategic blueprint. It's where all that patient data you gather actually turns into a real measurable plan for getting better.
Yeah, it really sounds like the foundation for care that's accountable and truly focused on the patient.
Exactly. So our mission today is to unpack those critical pieces for you. We'll really zero in on clinical judgment, that's huge, and how nurses figure out priorities,
Hmm.
plus setting measurable outcomes, choosing the best interventions, and how essential collaboration and communication are. We'll use examples like the Mr. Lawson case study from the chapter to make it real and connect it all back to, NCLEX competencies and best practices.
Perfect. So let's start right at the beginning. What exactly is planning in nursing?
Well, at its heart, it's identifying a patient's problem, often through that nursing diagnosis we've talked about before, and then creating an action plan aimed at a specific outcome.
But way more involved than planning dinner.
Oh, definitely. It demands serious critical thinking, really sharp clinical judgment. You're reviewing diagnoses, prioritizing them carefully, setting those clear, measurable goals or outcomes, and then picking the interventions that fit that specific patient.
And that judgment piece, that sounds like where the art and science really blend together, doesn't it? Making those calls about priorities and interventions, like a conductor leading an orchestra.
That's a great way to put it. Clinical judgment is totally the guiding force. It's how nurses make the right calls during planning, and it's fueled by several parts of critical thinking.
Like what?
Well, first, your knowledge base. It's not just knowing A and P. It's applying your understanding of the patient's condition, the assessment data, nursing principles, even knowing about other resources like community support or family dynamics.
Okay, like with Mr. Lawson in the book. His nurse, Tanya, uses her knowledge about his surgery, a colectomy, and the risks, like a pulmonary embolus, a blood clot in the lung. That knowledge shapes her plan.
Exactly. She knows recovery stages, potential complications, even teaching principles because she needs to educate him. Then there's the environment.
How so?
Things like hospital staffing, how busy the unit is, interruptions, they all affect timing and efficiency. Or in home care, it might be visit schedules or who's there to help.
Right, practical realities.
And experience is huge. The more you see, the better you get at anticipating changes and knowing what works. Your judgment gets stronger. Even attitudes play a role, like being creative to make a plan truly patient-centered, or disciplined enough to make sure it's thorough and evidence-based.
So, with that kind of judgment, a nurse isn't just listing problems, they're seeing an order to them. Which brings us to prioritizing. That sounds like a constant juggling act.
It absolutely is. Priority setting means ordering those diagnoses or problems to decide what gets attention first. And it's super dynamic, things can change in minutes, so you're always reassessing.
So how do you decide? Is there a general rule?
Generally, yeah. Problem-focused diagnoses usually take priority over things like wellness or health promotion. Short-term, acute needs often come before chronic ones.
Okay.
And a fundamental starting point is always the ABCs. Airway, breathing, circulation, that's your highest priority typically.
Right.
Maslow's hierarchy is another useful framework, basic physiological needs first. You kind of mentally sort diagnoses into high, intermediate, and low importance.
But it's not always just about the physical stuff, is it?
Not at all. That's key. Even something non-physiological, like risk for violence, could absolutely be a high priority depending on the patient's situation. You have to look at the whole picture.
Let's go back to Mr. Lawson. How did Tanya prioritize his care as things changed?
Well, initially, his acute pain was top priority. Makes sense, right? If pain's out of control, it affects everything. Recovery, moving, even learning what he needs to do.
Okay.
But once his pain was better managed, lack of knowledge became more urgent, especially with discharge getting closer. He needed to learn how to care for himself post-op.
And infection risk.
Risk for infection was sort of an intermediate priority, something to watch constantly. If his wound showed signs of trouble, boom, it becomes high priority. His anxiety was initially low, but Tanya kept an eye on it. If it started interfering with his learning for discharge, its priority might need to bump up.
That really shows how quickly things shift and how specific knowledge, like recognizing chest pain post-op as a possible PE sign, demands immediate action.
Exactly. That's why nurses are constantly making what we call cognitive shifts, switching focus between patients or tasks based on changing needs, new orders, or even just the environment, like a call light going off. You have to be organized and know your patient's current status.
And it's not just the nurse deciding alone, right?
No, definitely not. You collaborate with patients, families, other providers. Their input is crucial. Sometimes priorities differ, and you need open communication to sort it out, always keeping the patient's best interests front and center.
So here's a critical thinking question for you listening.
Hmm.
Imagine a patient has both increased pain and increased anxiety at the same time.
Hmm.
How would you decide which is the higher priority, giving pain meds or trying stress reduction techniques?
Oh, that's a classic nursing dilemma. And honestly, there's no single textbook answer without knowing the specific patient. You'd have to assess both the pain and the anxiety. How severe are they? What are their characteristics? And crucially, how are they influencing each other? Like, is the pain so bad the patient can't even try a relaxation technique? Then maybe the pain med comes first, just to open a window for other things.
Oh, the other way around.
Right. Or maybe the anxiety is clearly making the pain feel worse. In that case, tackling the anxiety might actually make the pain medication more effective or maybe even reduce the need for it. It's about seeing the interplay and figuring out what's causing the most immediate distress or barrier to progress for that patient.
That makes a lot of sense. Okay, so priorities are set. Now you need to define what success actually looks like. How do nurses figure out the right outcomes?
Right, outcomes. An outcome is basically the effect your intervention has on the patient's health status. Expected outcomes do two really important things. One, they point you toward the right interventions, and two, they give you measurable criteria to see if those interventions actually worked.
So you know if you're on the right track.
Exactly. Nurses ask things like, does the patient agree this is the goal? What's the best approach here? What does my patient really need to achieve? And critically, how will I know when they've achieved it?
So for Mr. Lawson, with his risk for infection, Tanya wanted him infection-free. The outcomes might be things like him staying afebrile, no fever, having no wound drainage, and seeing the wound edges healing nicely by discharge.
Perfect examples. Those are measurable. You can check his temperature, you can look at the wound. That ties into nurse-sensitive outcomes.
What are those exactly?
These are super important for measuring the quality of nursing care itself. Their patient, family, or even community states, behaviors, or perceptions. Things like pain levels, functional status, infection rates like SAUVIs or CLAB size, patient satisfaction that are directly influenced by what nurses do.
So they're different from purely medical outcomes, like whether a tumor shrinks.
Exactly. Things like mortality rates or surgical site infections are more directly tied to medical interventions, though nursing care obviously contributes. Nurse-sensitive outcomes really focus on the impact of nursing practice.
And is there a way to standardize these? I think I saw something called NOC.
Yes, the Nursing Outcomes Classification, or NOC. It's a fantastic resource, it's standardized, and it links specific outcomes back to the NANDA nursing diagnoses. It gives you labels, like the overall goal, say, pain control, and then specific indicators, the measurable criteria, like reports pain severity using a pain scale, often a 0-10 or 1-5 Likert scale, so you can track progress objectively.
Okay, so you have these outcomes. How do you write them down so they're actually useful day to day? Why bother being so specific?
Great question. That's where the SMART model is indispensable. It stands for specific, measurable, attainable, realistic, and timed. And why bother? Because vague goals like patient will feel better are useless for guiding care or evaluating success. SMART turns fuzzy wishes into a clear roadmap.
Can you break down SMART a bit more?
Sure. Specific means it focuses on a single patient behavior or response. Avoid trying to lump multiple things together. Measurable means you can actually observe or quantify the change, physiological signs, knowledge, perception, behavior. Don't use vague words like normal or stable. Use precise terms like numbers on a scale, frequency, distance walked, etc.
Okay, like Mr. Lawson reports pain at 3 or less on a 0-10 scale by discharge. That's specific and measurable.
Exactly. Attainable means it's achievable for that patient, ideally set collaboratively. Is it realistic given their condition and motivation? Like, Mr. Lawson will describe 3 infection risks within 24 hours. That's attainable if he's alert and willing.
And R is realistic. Seems similar to attainable.
It is similar, but realistic also brings in the context patient preferences, resources available in the hospital or at home, their overall potential. It also means communicating realistic outcomes if they're moving to another setting, like rehab. And timed means you set a deadline. Mr. Lawson walks the chair with assistants twice today. That time frame creates accountability and helps you see if the plan is working.
And you mentioned involving patients and families in setting these goals, even if their priorities maybe differ from the nurses.
Absolutely critical for patient-centered care. You need to understand what matters to them. If there's a difference, you talk it through, explain the rationale, but always respect their values while ensuring safety. This collaboration isn't just with the patient, it's with the whole team. Patient care is complex now. Interprofessional collaboration is essential, different professionals working together for common goals.
Got it. So smart outcomes are set. Now, the doing part, choosing the actual interventions, what's in the nurse's toolkit?
Okay, nursing interventions. These are the treatments or actions based on your clinical judgment and knowledge that you perform to help the patient achieve those outcomes. Choosing the right ones means drawing on your nursing knowledge, the scientific evidence that's evidence-based practice, EBP, and what you found in your patient assessment.
Experience helps too, I bet.
Oh, definitely. Experience refines your ability to pick the best intervention and maybe tweak it for a specific patient. Remember Tanya using a PICOT question to find evidence for teaching Mr. Lawson. She chose things like a hospital TV program, but also tailored wound care teaching to his gardening hobby to make it more relevant.
So interventions aren't just picked from a list. They're really tailored.
Yeah.
And I recall they fall into different types.
Yes, several ways to categorize them. You have direct care things done with the patient, like giving meds, changing dressings, helping them walk, and indirect care things done away from the patient but for them, like documenting, managing their environment, consulting with other team members,
Okay.
and then crucially, who initiates them. Nurse-initiated interventions are independent things a nurse can do based on their assessment and judgment without a doctor's order, like repositioning a patient to prevent skin breakdown, teaching relaxation techniques, counseling. Tanya independently positioned Mr. Lawson for comfort.
And the others?
Healthcare provider-initiated are dependent. They require an order from a physician, NP, or PA. Things like administering specific medications, inserting a Foley catheter, ordering diagnostic tests. Tanya needed orders for Mr. Lawson's pain medication.
Makes sense.
And finally, other provider interventions, sometimes called interdependent or collaborative. These require the combined expertise of multiple disciplines, like working with physical therapy on mobility or social work on discharge planning. Tanya collaborated with the discharge coordinator for Mr. Lawson's home health.
And it's vital nurses question orders if they seem wrong.
Absolutely vital. You are legally responsible for your actions. If an order seems incorrect, unsafe, or inappropriate, you have a professional and legal duty to clarify it before carrying it out. You can't just say, I was following orders, if harm occurs due to an error you should have caught.
It's a huge responsibility. So beyond the type, what else guides the choice of intervention?
Several key factors. Number one, does it align with the desired patient outcomes? The intervention should directly help achieve that SMART goal. Number two, does it address the characteristics of the nursing diagnosis, the cause, etiology, the signs and symptoms, or the risk factors?
Okay.
Number three, what's the research base? Is it evidence-based? Does it follow scientific principles and standards of care? 4, feasibility. Can we actually do this? Consider time, cost, available resources, patient limitations. Like, planning frequent walks is great, but is there enough staff to assist safely?
Good point.
5, acceptability to the patient. Does the patient understand and agree? Does it align with their values, beliefs, culture? Offer choices when possible. And 6, capability of the nurse. Do you have the knowledge and skills to perform the interventions safely and effectively? Can you manage the resources needed?
Wow, a lot to consider for every action. Is there a standardized language for interventions too, like NOC for outcomes?
Yes, there is. It's the Nursing Interventions Classification, or NIC. Like NOC, it provides a common, standardized language which really helps with communication, documentation, and comparing the effectiveness of care.
How's it structured?
It has different levels, broad domains like physiological, basic, then narrower classes like physical comfort promotion, and then the specific interventions like pain management, which lists detailed activities a nurse might perform, such as ensure prompt analgesic administration or use non-pharmacological relief measures. It covers both independent and collaborative actions.
Okay, so we have diagnoses, priorities, SMART outcomes, and selected NIC interventions. How does this all come together in the real world across a whole hospital or healthcare system?
Great question. That leads us to the systems used for planning care. The cornerstone is often the nursing care plan.
The document itself.
Right. It includes the diagnoses, outcomes, specific interventions, and how you'll evaluate. Its purpose is continuity of care, clear communication for the whole team, reducing errors, and coordinating resources. Nowadays, these are often electronic, part of the EHR.
Using those standardized languages like NANDA, NOC, NIC.
Often, yes. That promotes consistency and quality, but they must still be individualized. Increasingly, especially with complex patients, you'll see interprofessional care plans. These integrate contributions from all disciplines, medicine, nursing, therapy, social work, everyone involved, which really improves coordination.
And when shifts change or a patient moves units, how does the plan travel?
That's where handoff reporting is critical. It's the formal process of transferring essential patient information, responsibility, and the plan of care from one caregiver to another. It's vital for catching changes, anticipating risks, and ensuring nothing falls through the cracks.
I've heard about bedside reporting being better.
Yes, there's good evidence for bedside reporting. Doing the handoff right at the patient's bedside, involving the patient and family, if appropriate, tends to improve safety, patient satisfaction, and even nurse satisfaction. It makes the transition smoother and more transparent.
Now, for nursing students trying to visualize all these connections, diagnoses, data, interventions, the book mentions concept maps. Can you describe what those are, like figure 18.5 for Mr. Lawson?
Concept maps are fantastic learning tools. They're basically visual diagrams. You put the main issues or diagnoses in the center, and then you draw lines connecting them to relevant assessment data, planned interventions, and even outcomes. It helps you see the relationships between different problems and interventions for a single patient.
So it paints a holistic picture.
Exactly. It forces you to think critically about how everything links together rather than just seeing a list of disconnected tasks. Great for developing that clinical judgment we talked about.
Then there are things like critical pathways or ERES protocols. What's their role?
These are often used in hospitals for specific patient populations or procedures, like knee replacement or, as you mentioned, ERS, enhanced recovery after surgery protocols. They standardize care based on evidence, aiming to reduce unnecessary variation, shorten hospital stays, and improve outcomes. They often outline key interventions or goals for each day post-op.
Sounds efficient. Any downsides?
The main potential pitfall is focusing too much on the pathway or protocol and losing sight of the individual patient. Care can become fragmented if you're just checking boxes for the disease instead of caring for the whole person. That's why the book emphasizes, and it's crucial, clinical judgment always outranks the use of a care path. You adapt the path to the patient, not the other way around.
Good reminder. Okay, last piece. Sometimes you need help beyond the immediate team, right? Consultation.
Yes. Consultation is when you seek out specialized expertise for a particular patient problem that you or the team are struggling with. It's usually more focused than ongoing collaboration.
How would you do that?
When you've hit a wall, basically. When the problem persists despite your interventions, or when you need knowledge or skills beyond your scope or the team's usual expertise.
Is there a structured way to consult?
A really helpful framework, especially for critical conversations, is ISBAR. Identify yourself and the patient, describe the situation, provide relevant background, state your assessment of the problem, and make a clear recommendation or request. Being prepared, clear, objective, and available to discuss the findings makes the consultation much more effective.
Okay, so we've really covered a lot today, the whole process of planning nursing care. It's definitely an art and a science.
It truly is. We've hit on clinical judgment, prioritizing, setting those vital SMART outcomes, choosing evidence-based interventions, and the absolute necessity of teamwork and communication.
Understanding these principles really forms the backbone of effective nursing, doesn't it?
Absolutely. It's what empowers you as students and future nurses to provide care that is safe, effective, and genuinely centered on the patient's needs. It gives you the framework to navigate those complex situations with confidence.
So, as we wrap up, here's a thought to leave you with. How might new technologies, things like artificial intelligence, maybe helping with clinical decisions, change how nurses plan and prioritize care in the future? What new skills might nurses need to use these tools well while still keeping that essential human connection at the core of care?
Something definitely worth thinking about. Thank you so much for joining us for this deep dive into nursing planning. We hope this helps you on your nursing journey. Remember, you're part of our learning community, and we wish you all the best.